Hi everyone. So
Hi.
people are now connecting, and so it will take a little bit of time for everyone to enter the room. So we'll wait for 5 minutes, and during that time I will present myself. So I'm Clémentine Schild. I'm the head of digital education at Institut Pasteur in Paris, and I would like to welcome you to this live event of the Viral Hepatitis MOOC. I would like especially to thank our directors, Françoise Lunel-Fabiani, Stanislas Paul, and Dominique Franco, and our community manager, Stefania, who coordinated this MOOC. So this live session will be in English. If you can't write your question in English, please write it in French, and we'll try to answer it preferably in English and if possible in French for questions that were asked in French. And so it will be recorded and the replay will be available in a few days. I will ask everyone also to present yourself in the discussion using the discussion button. But if you have some question, please use the Q&A button. And I will leave the floor to Stefania.
Hi, everyone. I'm Stefania, your community manager, which contacted you by email weekly. So yeah, before we will start, I would like to remind you about the certificate of attendance. Just a few seconds, I will share my screen. Yeah, I hope you see it all. So yeah, you can get a certificate of attendance in case you successfully complete an exam, and please register before 7th of June, and the cost is 150 euro. And in case you collect 5 of this kind of certificates from 5 different MOOCs provided by Institut Pasteur, you can be awarded by the diploma for all the infectious diseases. Just keep in touch with people related to this initiative, and please check all the MOOC enrollment available, and of course follow us on Twitter. So just I would like to, of course, present our directors, Françoise Lunel-Fabiani, Stanislas Paul, and Dominique Franco, without which this MOOC could not be possible. So I let them to present themselves. Please, Françoise.
Hello, nice to meet with many people, I hope, today. I'm Françoise Lunel-Fabiani. I'm a virologist in University Hospital of Angers. I'm also a hepatologist, and I'm very much involved in programs in Africa and low-income countries about hepatitis B, hepatitis Delta, especially. That's all for the moment.
Stanislas.
Dan.
Hello, everybody. My name is Stanislas Paul. I'm a professor of hepatogastroenterology in the University of Paris Cité in France. And I'm mainly involved in the care of viral hepatitis and liver disease in Hôpital Cochin.
Thank you, Paul. And Dominique?
Hello, I am a liver and transplant surgeon, so I am more interested by the relationships between viruses and hepatocellular carcinoma.
Thank you, Dominique. So yeah, this MOOC could not be possible technically without our MOOC team, Clémentine, our director, Odile, which is behind the scenes, Leonardo, and our intern, Ocean, and of course, but with me, I hope. So so we just collected all the questions we got from the Zoom inscription. We got all the questions from the forum, and I just sorted them according to the hepatitis type. So just let's drive directly to questions because we have a lot, and yeah, go ahead. So we start by hepatitis A. So despite, oops, sorry. despite the ameliorated sanitation and food safety, which decreased the occurrence of hepatitis B, cases of infection still occur or have a high risk to occur in war zone and in zone affected by natural disasters, floods in Brazil, Afghanistan, Indonesia, Kenya. What are the rapid and efficient methods to stop the spread of the hepatitis virus? And I think Stanislas can answer to this question.
Yes, so thank you for the question. The answer is really easy, at least in the principle. Of course, to stop the spread of HIV, it's only, in addition to sanitation and food safety, the vaccination against HIV, which allow the eradication of the infection. And the important point is that it is available since now more than 30 years, but it's not really very frequently used as a preventive therapy. And so I think that the message is there is an available, very efficient vaccine, which is called Avrix, or in combination with the HBV vaccine, Twinrix. And so it is important to make information around the need for this vaccination. And we know that it's very difficult for HBV. It's also very difficult for HIV, even in France, especially because it's not completely reimbursed. And so we have some cases yearly of children from high-risk areas which are coming back from the initial country who have fulminant hepatitis. So the message is vaccine, if you can have access to the vaccine, in order to decrease the risk of severe liver disease, which is not very frequent, 1 per 1,000 cases, but which may be very severe, especially given the endemic in some countries, and vaccine more and more in all the cases.
Okay, thank you a lot, Stan. So let's go to another subject. Oops, sorry. To the hepatitis B. So as you may know, in March, the new guidelines from WHO were released on hepatitis B, and what are actually the major updates compared to the previous version of guidelines. And here I have a supporting slide, and I think Françoise can briefly discuss these new updates.
Thank you. I will comment briefly because there is a lot of subjects, and we have some slides maybe to explain each point of its new point of these new guidelines published in March. It concerns treatment of adolescents and children with chronic hepatitis B. So there is new recommendations, which is the same than in adults, with some points, special points. We can maybe have the slide if you.
No, I only have this, sorry.
So there was a slide about that. There is also a recommendation for alternative antiviral regimens for treatment of hepatitis B, especially in countries where tenofovir alone or entecavir alone is not available. So recommendation also take the antiretroviral molecules like tenofovir plus another one, and also lamivudine plus tenofovir, for instance. So it is recommended to take dual therapies if monotherapies against hepatitis B is not available. But the point, the very difficult point is the is to obtain these molecules from Gavi or from Global Fund. And it is very difficult in some countries, especially I've been in Cameroon last month, and it is very, very difficult to obtain these molecules. So it is really needed to discuss with health ministries in each countries to obtain these molecules. But now, today, if there is antiretroviral molecules available, like tenofovir plus lamivudine, or tenofovir plus another nucleoside analog, the recommendation is to treat people with dual therapies. There was also recommendation about point of care and reflex HBV DNA testing. So recommendation are to detect hepatitis B virus infection is, of course, serological assay or dried blood spot assay or rapid test for the first detection. And then there are point of care DNA testing for HBV, and recommendation is to excuse me, to use this HBV DNA test. And now there is a lot of point of care automates, and which are used for HIV or tuberculosis, and now they can be available for HBV DNA testing. Excuse me. The other points are expanding access to antiviral prophylaxis for prevention of mother-to-child transmission. So as you know, there was a recommendation in the last guidelines in 2015 about treatment of preventive treatment for mother who were HBV infected. And of course, vaccination of newborns in the 24th third hours after birth. And now the guidelines are talking about maybe treating mother who are HBs antigen positive, but in countries where HBV DNA is not available, to treat all HBV antigen positive mothers. So it is a reflection, of course, because treatment is not available everywhere, but it is a recommendation if HBV DNA testing or HBe antigen testing is not available. There are also recommendations on HDV infection testing. These recommendations were not in the last guidelines in 2015 about who to test and how to test. The first recommendation is to test everyone who are HBs antigen positive, but in countries where the HDV testing is very expensive or too expensive for every people, there is recommendation to test at-risk patients, for example, patients who have cirrhosis, or patients who are in countries where HDV is very prevalent, or people who have very elevated transaminases. So that's the recommendation. And for HDV RNA testing, the recommendation is to test with molecular test every antibody, HDV antibody positive patients, but in countries where HDV RNA is not available, it is very difficult. So these are the main recommendation, the main new recommendation who are in the new guidelines of WHO.
Thank you, Françoise, for the very detailed, anyways, explanation. So let's pass to another question. Yeah, so actually that's what related to your question that you asked for, that the tenofovir is not like free in Africa, and that was the problem from the person which sent this comment. So yeah, and as you said, it's the problem with the Gavi and the Global Fund, which is not managed very well.
Yes.
Sorry.
Regarding the access to the let's say, these drugs, it's possible also to make, but it's not completely free. Some mail requests to obtain generic tenofovir pills. It has been very used in Asia, and so the price is around 20 cents per pill. So of course it's very lower than the French cost, around 11 to 15 euros. So you can make directly in India this command and to obtain the treatment. So of course it's not completely free, but really it's mainly discounted.
Okay, thank you very much.
Have different sites where you can make your command on the basis of a medical prescription. And so this is the same for drugs against HCV infection, and it's possible to have very discounted prices. Just as an example, for HCV, the cure is around $150 as compared to around $20,000 for the same treatment in the French market, at least.
Okay, thank you for important addition to this problem. So let's go to another question. Our student requests to clarify, given that HBEG and hepatitis B vaccines do not completely prevent hepatitis B in children born to hepatitis B seropositive mothers, is it necessary to screen all children whose mothers are hepatitis B seropositive? If so, when it's appropriate time? I think Stanislas can give us an answer.
Yes, first answer. We have to consider that the prophylaxis, passive and active prophylaxis with HBIG and HBV vaccine completely prevent the risk of mother-to-child transmission. So it's not completely correct to say that it's not completely efficient. It is completely efficient if you perform the prophylaxis just after the birth of the newborn. And so Françoise mentioned that it was within the first 24 hours, but in a trial that we performed in Thailand, we reported that performing this prophylaxis within the next 4 hours after the birth was as efficient than the use of tenofovir during pregnancy and the prophylaxis. So I think that we have to remember that it is very efficient if we do that. But it's true that there are some very rare cases of in utero transmission of HBV. And in this situation, as previously mentioned, there is this issue of treating the pregnant HBV-infected women during the second and third trimester of the pregnancy. And so that's why it is mandatory to test all the pregnant women for HBV infection and to anticipate this prevention in their newborns. So test and make the prevention, and in this situation, it's completely efficient. Of course, in some countries, and especially in Africa, it's not so easy to make the vaccination within the next hours after the birth, the delivery, because it's not an hospital delivery, because sometimes there is some concern about the chaîne du froid for the HB as well as for the vaccine. And so in this situation, of course, it's very difficult, but the message is to be as soon as possible in the prevention. And in this situation, it will be mainly efficient. The second answer is about the testing of the vaccinated newborns of infected mothers. In the recommendation, usually we recommend to control the absence of HBV infection, namely HBsAg positivity, around the 9th month of life. And of course, to confirm that the baby is HBsAg negative, which is mainly the situation, and if possible, anti-HBs positive, indicating that with this neutralizing antibodies, there is no expected risk for the future. Even if there is, in the teen age, a decline of the antibodies and the risk of being anti-HBs negative, but we know that the initial vaccination allows to be protected of the risk of chronic infection, because in addition to the humoral immunity, there is also a cellular immunity associated with the vaccine.
Okay, thank you very much for clarification. So we have a question from Laura, which asked 2 questions regarding the hepatitis B virus. So what is the expected cynetic of HBV viral load decrease after starting treatment, and when shall we expect undetectable viral load? What is the expected cynetic HBV viral load decrease after starting treatment?
Well, I can answer, at least for the second generation drug, we know that whatever the treatment, entecavir or tenofovir, and of course, according to the baseline viral load, there is, if there is a good adherence to the treatment, a constant decline with a slope which is varying, but 75% of treated patients have undetectable HBV DNA after 1 year of treatment. And the 25% who are still detectable at 1 year become undetectable in the 2nd year. So really, if you begin around 9 log of viral load, it takes time to become undetectable. But of course, it's completely different if you begin at 5 logs or 4 logs. Mm-hmm. And in this situation, you can bet that HBV DNA should be undetectable at 1 year.
So another question from her as well. Would you stop treatment to mothers HBsAg plus after delivery? Would it be a risk of flare? No. Would you stop?
Do you want to answer, or we can discuss?
Yeah. So yeah, just to quickly, would you stop the treatment to mothers HBsAg after delivery? Would it be a risk of flare?
Again, it depends on the baseline situation. So in those mothers who need a treatment, you will continue the treatment because they have chronic HB positive or HB negative chronic hepatitis, and there is a need to maintain the treatment for a long time. It will be probably a matter of discussion later. But if you are treating a mother who is anxious of the risk of perinatal transmission but with a low viral load or an HB negative infection, there is no need to continue the treatment. So what we are doing is usually to continue during the time of the breastfeeding and stopping after that. Laura is completely correct. There is a risk of flare, but usually really it's, let's say, asymptomatic flares, at least at the clinical level, and usually with a return to the baseline situation, which does not necessitate a treatment. And sometimes you can observe in those patients who had a rather high viral load, transition from the stage of chronic hepatitis to the stage of chronic infection, which does not require any antiviral treatment. So I think that in those mothers who do not necessitate a treatment according to the recommendation, which should be discussed later, we can consider stopping the treatment and, if possible, in the 3 to 6 months after delivery.
And thank you very much.
Really, it's mainly empirical, and probably Françoise may propose other recommendation. It's really a matter of discussion. In China, usually it's stopped at 1 month, and really it's depending on your access to the treatment, to the follow-up of the mother. So really, it's mainly a personal recommendation.
Just to add something, in mother who are HBe antigen positive with high viral load but normal LT, generally the recommendation is to stop the treatment 1 month or 2 months after delivery. But it can change in countries where the treatment is available or not, or only available for mothers. So.
Okay. Thank you very much for your answer about the hepatitis B. I guess we have another one question, which is related to hepatitis B and D, mostly super infection. And I think Françoise can answer this question. The HDV inhibits HBV replication in mother and therefore reduces transmission of HDV to the child during the birth. Why it is not true during sexual transmission or through intravenous drug use, since these are in all cases blood co-transmissions. By what mechanism can HDV produce an envelope with HBsAg once in the cell?
Okay, there is many questions. Thank you
Yeah.
for this question. You can see on this slide the 2 viruses, and you can see that hepatitis D is enveloped by the envelope of hepatitis B. So it is not, the envelope of hepatitis B is not produced by the Delta virus, but it uses the HBV envelopes to live in the host. May I have the question to the previous slide,
Yeah,
please?
of course.
Answer the question. So it is admitted that HDV inhibits HBV replication in the mother, yes, of course, and reduce transmission of HDV. There is very, very little literature about HDV transmission from mother to child. Very almost very few cases. Why is this not true during sexual transmission or IV drug use? This is not the same way of transmission in sexual transmission or IV drug, because sexual transmission or IV drug transmission takes place in people who are already HBs antigen positive, so HBV infected. They have a lot of HBV enveloped, and when hepatitis delta is close to these people by sexual contact or IV drug contact, HDV can enter the cell very easy because the envelope is there in the blood. If you can show maybe the entrance of HBV and HDV in the cells, yes, you can see here the HBV in the left part of the slide, the HBV particle, and with the receptor, which is NTCP. And so this is the contact, if you can say that, between the HBV envelope and the NTCP, which can permit the HBV entry in the cells. This is the same for HDV. HDV is enveloped by HBV envelope, and so it enters the cell via the same receptor than HBV. So the transmission is easy. In the HDV transmission is easy in patients who are already HBV infected or with HBs antigen in the plasma. If I have the next question,
The next
if it is
question.
clear.
I guess it's it's
No,
concerning.
there was another question. So
What do you mean?
in the last
Ah,
slide.
you mean this one? Yeah, I think it's by
Yes.
what mechanism HDV can produce an envelope with the HBs.
So HDV does not produce an envelope. It used the envelope of HBV, but not produce the HBV envelope. You can see here the replication, the viral cycle of HDV, the right part of the slide. And you can see that HDV does not produce the HBV envelope. It only produces the L HDV antigen and the large HDV antigen and the small HDV antigen, as you see here. So I hope I have answered the questions.
Yeah, it's very complex. Like the super infection is super
Yes.
complex, and it's
Complex.
another subject of discussion. So let's drive to another question concerning hepatitis B and D. With current therapies, can we negativize HBs AG? Maybe someone can give
Yes.
a brief answer.
The answer is yes, but it's a rare event. The loss of HBsAg occurs in patients who are treated by nucleosides or nucleotide analogs at a very low level. So you may consider, at least with tenofovir, that it's around 5% at 5 years of treatment. So it's very low, but it's possible. And you may also observe the seroreversion with HBsAg loss and the occurrence of anti-HBs, suggesting a complete recovery of the infection. But we know, and probably Françoise will comment, that there is still some HBV DNA in the nuclear of the hepatocytes, either as a cccDNA or either as integrated HBV DNA, which may result in reactivation. So we have to consider that there is no complete cure of HBV chronic infection. Regarding HDV, the answer is a little bit different. So it's possible to achieve a complete recovery of the HDV infection. And so in this situation, HDV RNA is undetectable during the treatment and after the end of the treatment. So the treatment may have some varying duration. And this is a true recovery. And so in this situation, you still have detectable antibodies, anti-HDV antibodies, and you have still usually the chronic infection with HBsAg. And in this situation of recovery of chronic HDV infection, there is a risk of reactivation of HBV infection. But sometimes the recovery of HDV is associated with the functional cure of HBV, especially at the time of treatment using interferon alpha. And so you had patients with B and D infection cured of HDV and HBV infection with HBsAg loss. So it happens, but it's not a very frequent event in chronic HBV infection or chronic B and D infection.
Thank you very much, Stanislas. So we have a question from Agata, which asked, it's in the same subject of the treatment. Will we have the combination of treatments if the child is born with both diabetes and hepatitis? Are there any side effects of the treatments? But I don't know which kind of a hepatitis. She just mentioned hepatitis without type.
Well, if it's hepatitis B, so we have now mainly 3 treatments. According to the countries, lamivudine, the oldest, which is the first generation with a risk of resistance, which is around 25% per year. So it's very significant. And we have the second generation MOOCs, entecavir and tenofovir, without significant risk of mutation. And so, of course, we have to choose one of those second generation drugs when it's possible. It's very well tolerated, and we can consider that there is no very significant side effects. No side effects for entecavir, some discussion, but which are mainly commercial discussion around the renal risk of the tenofovir, with an accumulation of the metabolites of tenofovir in the proximal renal cells, which may induce hypophosphoремia and a risk of renal failure. But this is mainly observed in patients with pre-existing renal disease, including HIV infected. So that's why we need with tenofovir to make, and entecavir also, but to make a follow-up of the renal function. But usually it's very well tolerated, and people are living completely normally. And there is no major link between diabetes and hepatitis. We know that hepatitis C increase of 1.5-fold the risk of diabetes, type 2 diabetes. Hepatitis B has been associated, at least in a Chinese study, with diabetes, type 2 diabetes, but it's not a major issue. And so we have to consider only one treatment. There is no additional value of the combination of entecavir plus tenofovir, and to reassure the patient that there is no specific risk associated with MOOCs.
Okay, thank you very much, Stanislas, for your update about hepatitis B and D and also additional diseases. So we can switch to the subject related to the comparison with the hepatitis B and C. So it seems that the chronic HBV infection is deadlier than HCV. What are the key major differences between hepatitis C virus pathophysiology compared to other hepatitis types? But I guess you just answered, Stanislas, for this question about the why HBV is not very well treated. Yeah, I leave you floor. Yeah, please. Stanislas?
I thought it was Françoise, excuse me,
No,
but
whatever
I'm
you-
sure that Françoise
Françoise
should better explain than me. Françoise, no?
Oh, the main difference between HBV and HCV is, of course, that HBV, it's a kind of retrovirus because it's not a retrovirus, but it's a virus that replicates through RNA intermediate, and the main thing is HBV replicates in the nucleus and can integrate into host genome. Whether HCV, it's RNA virus, but it does not replicate through a DNA translate. And the replication of HCV is cytoplasmic. And so the drugs against HCV are very efficient, and the drugs against HBV are efficient in the replication how I can say that, in the replication, cytoplasmic replication forms, but it does not destroy the CCC DNA of HBV, which is in the nucleus, and maybe new molecules may be more efficient and can enter the nucleus, but for the moment it is not, these molecules are not available. So for HCV, the HCV disease is very can be very severe, but the treatment is completely efficient, and patient treated for 3 or more months by new DAA are completely have completely recovering of HCV infection.
We have a question here related to the triple infected patient with HIV, HBV, and HDV. Is there any special care for this triple infected patient?
No, it's exactly the same treatment. So, of course, we have to consider the control of HDV infection, which is not so easy, by using interferon and or the new treatment, which is bulevirtide, which is an inhibitor of entry of HBV and HDV, which is not so easy to use because first, very costly, and second, you have to perform subcutaneous daily injection of bulevirtide. But it's true that in association with pegylated interferon, it increases the rate of HDV cure. So the natural history is approximately the same today, given the immune restoration associated with the antiretroviral treatments. And so the discussion of treating or not treating HDV infection is the same, mainly based on the evaluation of the fibrosis of the patients. And regarding HBV, of course, for HIV-infected patients, there is always a combination of antiretroviral drugs, including an inhibitor of the reverse transcriptase. It's mainly the tenofovir, and frequently a combination of tenofovir and antricitabine in Truvada or in other quadruple combination. So it's always a control of HBV infection without HBV cure, and a discussion of the treatment of HDV with or without HIV.
Thank you. So we have another question this time regarding to hepatitis C. So our student asks about the hepatitis C vaccine. It is not clear how we can have a vaccine in the view of the possibilities of the reinfection after, I guess, the efficient treatment?
Well, today there is no available HCV vaccine, but probably it will be interesting, as mentioned, especially as a primary prevention or in the prevention of reinfection in patients who have been previously infected and treated. There are some very encouraging development, especially in Tours,
Yes.
a city in France, where the first HBV vaccine has been developed 50 years ago, and using the same approach, which is not a serological approach, but a genetic approach combining HBV and HCV prevention. And so using envelope epitopes of HCV, there is some hopes for this successful development of a dual vaccine against HBV and HCV. But it's not already, of course, in the clinical trials.
Okay, thank you very much. So I guess we have another question, kind of a general question, which we received also by our registration form. Is there a lack of fundamental knowledge for in vitro viruses replication?
Françoise.
I think there is no lack of fundamental knowledge for in vitro HBV or HCV virus replication. Replication of HBV is possible in vitro using hepatocyte culture or hepatoma cells culture. And for HCV, it is the same. It is possible. And also using other system of replication, which are difficult to explain without slides. But there is, for the moment, I don't think there is a lack of knowledge for in vitro viruses replication. No.
Probably the main lack is about the immunology knowledge.
Yes, that's true.
Because it's true that in HCV you have some immune response, but which is not sustainable. And so there is this risk, high risk of chronic infection, high risk of reinfection without neutralization of the new virus. And so there is probably a need for immunological research of at least HCV and HDV.
Okay, thank you very much. So I have a question from my side as a structural biologist, which worked with viral proteins. So are there any available like gene therapy, for example, against hepatitis B virus? Because there are like a lot of things which are going on, but are there any like research done or any like I don't know, because we are talking about the small molecules, but could we consider also the gene therapy to actually eliminate in the future the HBV occurrence?
Well, if we consider that RNA interference, for example, is genetic therapy,
Yes.
there is some clinical trials which are ongoing. A paper this year in the New England for a phase 2 study of bepirovirsen, which is interferent RNA of HBV. So there are those kinds of developments, but which are mainly with RNA inhibition or interference. And to the best of my knowledge, they're restricted to HBV, which is the, let's say, clinical need.
Yes.
Okay, thank you very much for your answer. Do we have other questions? Yeah, we have a question from Serge. Can HCV, HBV, or I guess it's HDV, because it's repeated, can be completely treated?
The answer
We
is
did already
yes.
answer, yes.
For HCV and HDV, it's yes. Today, HCV cure is obtained in more than 98% of treated patients with 8 to 12 weeks of antiviral oral treatment. So really, it's the end of the question. Regarding HDV, yes, it may be completely treated because there is no reservoir, and so in around 1/3 to less than 50% of treated patients with bulevirtide and pegylated interferon, we may hope for a cure. But I think that regarding bulevirtide, we have to wait for long-lasting follow-up of the patients because we had previously some frustration regarding the HDV cure because a lot of undetectable patients had some relapse after 2 years without detection of HDV RNA. And finally, as previously mentioned, there is no cure today of HBV chronic infection because there is still, and for a very long time, persisting cccDNA, which are episomal form of HBV DNA in the nucleus of hepatocytes, and also, and mainly, I will say, integrated sequences of HBV DNA, which may target the viral direct hepatocarcinogenesis, resulting even in the absence of underlying liver disease in hepatocellular carcinoma. So really, even if there are all these initiatives around HBV cure, decreasing to HBV functional cure, we have to maintain the concept today that HBV is not curable. But there are a lot of therapeutic development. We have discussed the interferon RNA. There are also some immune vaccines and a lot of new drugs with fragmentation of cccDNA. So really a lot of developments, but today chronic HBV is not curable.
Thank you very much. So I don't know why, but in the last minutes we have a lot of questions. So yeah, another question just quickly before the end of the session. A colleague from Congo told me that they got a patient who achieved HBsAg seroclearance after about 10 years of HBV chronic infection without any treatment. Have you already faced such cases, and what could be plausible explanation to that?
Yes, in the clinical practice, really, it's daily. So I said previously that HBsAg loss is a rare event under nucleosides or nucleotides analogs treatments. But in the natural history of chronic HBV infection, we are observing some change from chronic hepatitis to chronic infection, HB positive, HB negative serological pattern. And in those patients who achieve undetectability of HBV DNA spontaneously, we know that the risk or the chance of HBsAg loss at 3 years, at 5 years is around 30%. So these are not very rare events when a given patient is auto-controlling its infection. But we have to remember this previous history of integrated HBV DNA sequences in the host genome of the patient with still persisting risk of hepatocarcinogenesis, even if after HBsAg loss, the risk is very low. So again, it's a virological or serological cure, but my recommendation is to maintain a follow-up of those patients, even if there was no clear underlying liver disease at baseline. and Christian Bréchot in Pasteur 50 years ago have reported that most of hepatocellular carcinoma without HBV infection had integrated HBV genome in the DNA, suggesting again viral hepatocarcinogenesis without the current markers of the infection. So if you know that there was this prior chronic infection, I think that even with this very good news at the serological and virological level, there is a mandatory need for maintaining at least yearly ultrasonography of the liver.
Thank you very much for your answer. We have other questions, but we don't have time. We will try to answer them on the forum as soon as possible. So we have 4 minutes left, and I would like to give a stage to maybe Dominique to give your final words to conclude this session, and also to Clémentine after. Thank you.
Well, I want to thank Françoise and Stan for answering so briefly and so well the questions which were very numerous and difficult to answer sometimes. And I think it was a very good webinar, and I thank all participants to be so careful and to ask so many questions. Thank you.
Yes, so thank you, Stanislas and Fabienne, and there were 37 learners from different countries like Madagascar, Guinea, Mali, Benin, Haiti, Cameroon. So sorry for, I know a lot of you would have preferred French, but some of you were not speaking French, so we kept this live session in English. But so thank you everyone, and thank you for your nice question and very nice answer.
From my side, also, I thank you very much for participation. Thank you for our MOOC directors, the true professionals. From my side, I see the true professionals and our professional MOOC team. And see you on the forum in case you have questions. And don't forget to register for the exam. The registration starts on the 28th of May, and the end of the course will be the 12th or not, Clémentine? It's 12th of June. Yeah, somewhere mid-June. So hurry up, and see you soon. Bye.
Thank you,
Bye.
bye.
Thank you very
Stéphania.
much.
Thank you, Stéphania. Bye.
Merci à tous, à bientôt.
Au revoir.